All right, good morning and good afternoon, everyone. I'm so pleased to welcome you to this Health Begins webinar on health equity and institutional accountability. I'm Grace Rubenstein with Health Begins. And just a couple of notes before we dive in. I want to let you know that this webinar is going to be recorded and we will share the recording out to all registrants after the webinar. Your lines as participants will be on mute, but we are really eager for a lively discussion here. And so you will have access to the Q&A pane and the chat window. And we really encourage you to go ahead and dive into discussion there and post any questions you might have for our panelists in the Q&A. We'll be saving a lot of time at the end to go through as many of those questions as we can. This is a 1-hour presentation. And with that, I am honored to introduce our host for today, Health Begins CEO, Rishi Manchanda.
Grace, thank you so much. And let me go ahead and start sharing screen here. Thank you so much to all of you for joining today. It is a real honor and a thrill to be on this panel with some esteemed panelists right now and to moderate this discussion. And so you'll hear from them shortly. This conversation is health equity and institutional accountability, setting a new standard for healthcare. I am Rishi Manchanda, CEO at Health Begins, and I'm joined by my colleagues at Health Begins as well. Thank you for joining us. The conversation today is part of a pace setter series that we started earlier this year. Pace setters are the individuals and the institutions from diverse backgrounds who are at the leading edge of this movement, this upstream movement to improve care and the social and the structural drivers of health equity. So thank you for joining us, and stay tuned for more coming up. Grace reviewed some of the reminders. We'll use our chat for comments to share resources. Please do so. We encourage you to use the Q&A function for questions, and we'll answer those questions, some of them as we can get to them in the latter half of the webinar during our fireside chat. Please bring and share respect, curiosity, and joy in today's session. More now than ever, we need all of these things in our discourse. And then today, during and after the webinar, please feel to engage with us on social media. You can tweet us. We'll put Twitter handles in for ourselves and our panelists into the chat as well. So I want to say a special shout out to our co-sponsor for today, the Rethink Health work, the initiative, which is an initiative of the Ripple Foundation. So thank you to our friends from the Ripple Foundation, Rethink Health team that are joining us today as well. I'm also going to give a highlight to a report. You'll see a link to that in the chat as well. A report that came out, they published in January of 2021 called Community Influence on Nonprofit Hospital Systems, which profiled several constituent or community organizing efforts that are focused on hospitals as a real example, a really in-depth, rich set of case studies looking at how external stakeholders, community members, constituents have participated in helping hold their healthcare institutions accountable for health equity. Also want to ask you to stay tuned to watch this space, as some commentators say, to a report that's coming out later this summer called Bringing Light and Heat, a Health Equity Guide for Healthcare Transformation and Accountability. This is a report that, a guide that's been developed by a coalition of partners we've been privileged to work with, including Health Leads, Human Impact Partners, JSI, UCSF, Siren Center as well. So please stay tuned for that, and you'll hear more about that in upcoming weeks. The question at hand right now, as I kind of set the table for this conversation, and you hear from our illustrious panelists, is this: as healthcare systems begin to implement health equity and racial justice strategies and measures, as we're seeing more of these measures and strategies come together, the fundamental question is, how will healthcare be held accountable by stakeholders for that work? That's the magnifying glass, right, that community members can apply to healthcare systems to be able to make sure that this work is done well, that it's done equitably. Does it make sense to solely rely on benevolent, progressive institutional leaders to make change if there's no system for accountability more broadly to ensure that change is meaningful? These are some of the questions that we'll get into, and it feels like it's a timely question given a lot of what's happening in the national discourse. To unpack that question and many others, I'm really privileged to be joined today by Dr. Michelle Morse, Deputy Commissioner for the Center for Health Equity and Community Wellness, as well as the inaugural Chief Medical Officer at the New York City Health Department. Michelle, thank you for joining us. Also joined by Dr. Bhadelia, Medical Director of the Special Pathogens Unit and Associate Professor at the section of infectious diseases at BU at the Boston University School of Medicine, and Professor Alnoor Ebrahim, Professor of Management at the Fletcher School of Law and Diplomacy, as well as a joint appointment at the Tisch College of Civic Life at Tufts University. You'll see a lot of the components that we're going to share today actually derive from much of their work, including Professor Ebrahim's. So we have learning objectives, which I think you've all seen if you registered for this webinar. I won't belabor this point too much, but we do want to make sure that you leave here with a better understanding than you started of different components of accountability and concrete near-term steps to take to help strengthen those components. Before we jump into our kind of opening remarks from our presenters, let's get a sense of who you are. I want to ask my colleagues to launch our first poll here. So go ahead and just let us know which kind of organization you're affiliated with. We'll leave this open for about 20 seconds. Great. Getting some really wonderful participation. Thank you. Another 5 seconds here. Great. Let's go ahead and end the poll. Majority of you voted, and it looks like we have a really interesting smattering. If you're part of the other group, please go ahead and in the chat, just type in the type of organization or your organization's name, if you will, as well. So please go ahead and put your name and your organization's name in the chat, if just to give people a sense of your organizational affiliation, and especially if you're in the other category. But looks like we have a nice spread here. We can stop that poll. And now that we all have a sense of who's online, let's go ahead and move to orient some of you to HealthBegins and get into this institutional accountability section. HealthBegins, as many of you know, is committed to improving the social and the structural drivers of health equity, because we know that that's a major way of being able to drive radical transformation in health equity. We have the privilege of working with a lot of different partners across the country for many years at the leading edge of defining what it means to move upstream. When we talk about moving upstream, we mean something very specific, and we're proud to see how this definition has been influential with a lot of our partners as well, which means to improve continuously and transform the social and structural drivers of health equity at all levels: individual health-related social needs, community-level social determinants, and of course, broader structural determinants of health equity. And we know, of course, this is about not just projects or one-off campaigns or a new initiative. This is about transformation, and it's transformation of norms, of practices, systems, and structures. Transformation is the key thing if we're going to be able to move at all these levels. And to do so, transformation must therefore be multi-level, right? At the population health management level, for example, where many healthcare systems lead, at the community health level, where many healthcare institutions partner, and at the societal health level, where many institutions can take a role in supporting efforts to dismantle structural determinants of health equity. So this multi-level solution, of course, has to be embedded in understandings of health equity and racial justice, both as processes and outcomes, and it's fundamental to our work. These days, as many of you are aware, there are many strategies and measures, or a growing number, I should say, of strategies and measures being recommended for health systems to advance health equity and racial justice. And so you can see at the bottom left, measures to help healthcare institutions, especially in the population health management kind of patient care deliveries context, improve equity for patients and their own staff on the bottom left. You can see emergent kind of models to suggest how we can hold institutions accountable for improving health of the community. To this recent Health Affairs article talking about new hospital rankings from Johns Hopkins and IBM. You can see also even in the top corner, again, tracking with societal health, what it means for health equity from a federal policymaking perspective as well. We're seeing emergent strategies and measures, and this is not going to be the conversation to list each specific measure that can be considered. We have a lot more that we can offer anybody who's interested, and can point you to wonderful resources that are emerging around measures and strategies. The question is, as we look at those measures and strategies that are emerging right now and we consider implementing them, again, what does it mean to hold us accountable? The components of institutional accountability actually aren't that difficult to grasp, right? Especially as we consider what needs to be in place for stakeholders to do this work. I'm going to introduce those 5 components here that we have compiled, and then turn it over to our opening remarks, and with this table being set now. These 5 components are community-centered governance and reparations, transparency, answerability, compliance, and enforcement or sanctions. Another way of saying the enforcement or sanctions is consequences. So, as we're looking at these components of institutional accountability and start to understand them, perhaps in the fireside chat, note that each of these components are mechanisms and that need to be in place if these emergent strategies or measures are going to be effective in achieving the end goal of advancing health equity and racial justice. Without institutional accountability and these components in place, we may run the risk of acting without impact, of working without real transformational change, of going through the motions without actually leading to meaningful improvements in health equity. Accountability is required. So to give our presenters a sense of what you guys are all doing here, let's launch the second poll. And Michelle, we're coming up to you in about 30 seconds, so thank you. But let's launch the second poll now and just get a sense of this. To what extent are you and your colleagues actively working to strengthen some of these components, however you define them, of institutional accountability? Not at all. You're a little, but mostly focused on developing strategies and measures. Somewhat, this is becoming one of your priorities, or you're very active. There's a lot of high-level interest and work across many stakeholders in this effort to drive institutional accountability. Great. Good number of responses so far. Let's wait another 5 seconds. Great, Grace, let's go ahead and close the poll and show everybody. This is really interesting, right? Not surprisingly, perhaps because you showed up for this conversation, many of you are at some various stages of at least engaging with these questions of institutional accountability. And I am curious, and I hope all of you are as well, about whether this is indicative of the field, or if you guys are all perhaps representing the leading edge of transformation in healthcare when it comes to institutional accountability. But suffice to say, this is a really good kind of grounding for all of us as we go into the conversation here. There's a lot of key framing questions, which I'll introduce at the end in our fireside chat. But as we think about now this table that I've hopefully set for you guys around institutional accountability and why it's so important, let's turn this over to bring this kind of ground us what this work looks like in practice with our first presenter, Dr. Michelle Morse. The mic is yours. Please let me know when I can advance your slides, and thank you for joining us.
Thank you so much, Dr. Manchanda. It's great to be with you all. It's a real honor to get the chance to really both share a little bit of the journey I've been a part of around institutional accountability, but also I'm really looking forward to hearing the questions and the dialogue, because a big part of why I agreed to be here is, we really, for the work that we've been doing, are trying to find colleagues who want to join in coalition and try to implement some of the model that we're proposing. And so very, very excited to hear your feedback and questions and comments towards the second half of the conversation today. So just really, again, honored to get to share a little bit about the journey I've been a part of around institutional accountability. It begins many, many years ago, but I'm going to be very brief. You can move to the next slide. About 6 years ago, I was moving back from living in Haiti, having done a bunch of global health equity work focused on health system strengthening and building back after the earthquake in Haiti, opening a 300-bed teaching hospital and starting the first 3 residency programs, a very intensive time in my life. And coming to the close of that era and moving back West, I was moving back when the Black Lives Matter movement was kind of really taking off in 2014 and 2015. And it was a time when our institution was really asking itself bigger questions. At the time, I was a faculty member at Brigham and Women's Hospital and Harvard Medical School. And we were asking ourselves, how can we do better, right? How can we not think about structural racism as some problem out there, but how is it actually happening within our walls? How can we elevate the examples of how institutional racism is operating at our institution and fix them, right? I mean, sounds simple, right? Not so simple. But we were really inspired by Dr. Kamara Jones's work and began working with her very closely as a part of this. And I should also mention that the organization I co-founded, which is called Equal Health, which colleagues and I co-founded back in 2010 after the earthquake in Haiti. We had also launched a global campaign against racism in partnership with Dr. Jones in 2018. And so all of that helped to accelerate some of this work. But the article that just came out a couple of months ago in the Boston Review really summarizes what was a 6-year journey. I should say not was, what is a 6-year journey. It is definitely ongoing. And what we describe in this article is essentially how the 6-year journey took us from a place where we couldn't even say the word racism out loud in meetings to a place where we were talking actively about what redress was needed, what restitution was needed to fix the issues of institutional racism at our hospital. And the way that we did it, the kind of project that spurred a lot of this dialogue, consciousness raising, and change work was looking at heart failure. Heart failure was the most common diagnosis for patients coming through our emergency room and our hospital at Brigham and Women's, and we've reviewed 10 years of heart failure admissions data from 2008 to 2018. And what we found was that systematically, the Black and Latinx patients were more likely to be admitted to the general medicine service. And I'm a hospitalist. I am a hospitalist at Brigham as well, or was at Brigham as well, and compared to the cardiology service. And thanks for putting the link to the article in the chat already. You beat me to it. And so with finding this is by definition institutional racism, right? We use Dr. Jones's definition, which is that racism is a system of structuring opportunity and assigning value based on how one's identity is perceived, which is what we call race, that systematically advantages some and disadvantages others and saps the strength of the whole society. So this is an example of an unfair use of resources or access to resources by race. And what we also found was that all of these other factors like insurance status and comorbidities were not a major player in this inequity. We did also find, however, that white patients were more likely to advocate to the emergency room doctor to be admitted to the cardiology service. And the doctors admitted that that was part of what drove their decision about which service to put the patients on. You can move to the next slide. So you can imagine this was not an easy series of conversations to have. And yet, over the years, through various partnerships, we were able to get to a point where we also trained out a cohort, essentially, of change makers. And this was in partnership with Southern Jamaica Plain Health Center, where we essentially had a program called Adaptive Leaders for Racial Justice. And this heart failure project was one of the projects that really helped to spur the training and action and conversations in that Adaptive Leaders for Racial Justice program. The reason I mention it is because, as you all know, change management in general is challenging, but particularly when it comes to anti-racism and other topics that are considered sensitive. And just to be clear, these are often sensitive for white people to talk about. So let's just be honest about that. And we found that we needed that cohort to be able to really change the culture around naming racism explicitly and moving forward. But what we also got into, of course, in the Heart Failure Inequities Project, as well as Adaptive Leaders for Racial Justice, is that colorblind solutions are not going to get us there. And we talk about this in the Boston Review article as well. We've had, as you see in these graphs here, from the 1960s up until now, yeah, we might see progress, for example, in median household income or life expectancy at birth. It's getting better over time for most groups, but the gap between Black and white has not closed in any of these metrics, particularly home ownership rate, where you see it diverging in this bottom left graph. So our feeling was very clearly that a race neutral or colorblind solution to the heart failure inequity would not get us to where we needed to be in terms of fixing this inequity, which we had 10 years of data showing, right? We can't wait another 10 years to fix this. Next slide. So instead, what we did was we said, let's go back to the incredibly rich intellectual heritage that the generations before us had created that really gives us solutions to how we might fix this particular inequity. And again, I can't emphasize enough how concrete we tried to be, right? It can be very easy to write lots of op-eds and do a lot of hand waving and talking, but what we really tried to do is be very concrete about what we were focusing on and what we were trying to fix. And critical race theory helped us to do that. It is a theory that has gotten, unfortunately, a lot of negative press in the last administration. I would say unrightfully so. And yet it is a very rich theory that is a legal theory created by legal scholars in the 1960s and 70s, but is really applicable to us today. So, and very helpful for us to kind of reframe how we're asking the question about why racial and ethnic inequities exist in health and healthcare. And then what we did in this, again, in this article and with this project was we said, well, we need, not only do we need federal reparations for Black American descendants of enslaved persons in the US as one of the most effective and just policy measures to end the racial wealth gap and to address our country's history, right? We can no longer be ahistoric in how we're thinking about these problems. But even if we get that, and that is like foundational to racial equity in this country, even if we get that, institutions still need to be held accountable because that's not going to end institutional racism. So it's a both and you can move to the next slide. We said that we want to use this model. We created a name for it. It's called Healing Arc. I hope, again, that you all will talk about it, use it, try it. Let us know if you want to try it. But the reason we came up with the framework Healing Arc, and I have to give this shout out to my co-author and co-conspirator on all of this work, Dr. Bram Wispelwey, who is brilliant with coming up with things like this. So acknowledge, redress, and closure are the three-part kind of prescription that Sandy Darity and Kirsten Mullen have put forward many times in their work around reparations. That the steps for healing are acknowledgement, redress, and closure, and that if we use Healing Arc in healthcare institutions and healthcare spaces, we might have a chance at actually ending these inequities instead of having another study 10 years from now showing the same thing. You can move on to the next slide. So I think, again, the point here is that it's a both and when it comes to reparations and institutional accountability for racial equity. And the Healing Arc model is an opportunity to be race explicit and to hold institutions accountable for this whole entire arc of what leads to racial inequities that builds on critical race theory and builds on, again, just change management and honest acknowledgement of the reality of racial inequities in healthcare and across the country. So thank you again for the opportunity to share this. And again, really look forward to the conversation and questions and hopefully people implementing Healing Arc.
Dr. Morse, thank you so much for that. And there's a lot of great chat and questions that are coming up already. I'm going to pass the baton now to Dr. Naheed Bhadelia. Naheed, welcome, and thank you again for joining us so much. I think that especially as we heard from Michelle right now, I think your comments are going to bring a really interesting perspective alongside that, especially when it comes to community governance and accountability. So thank you for joining us today, and Mike is yours.
Thanks so much, Dr. Manchanda. Just next slide. And I very much appreciate Dr. Morris's comments because the lessons that her organization have sort of shared resonate with what I'm going to say. And not only that, but I think, Michelle, you'll appreciate the commonalities between the same dilemmas, both nationally here and your prior work in Haiti, and some of the stuff that I'll talk about with global health equity. I'm taking a slightly different perspective. My expertise is in emerging infectious diseases, and I've spent much of my career either being on the front line as a responder to an emerging infectious diseases epidemic or outbreak, or trying to take those lessons and building resilience in our communities, in our healthcare systems, and in our policy making. And I'm going to start by saying, it should be obvious to everyone that the importance of, if it wasn't before, particularly now, the importance of health equity and racial justice when it comes to dealing with pandemic preparedness. I mean, it manifested in sort of the differences in the way that we saw different parts of our communities be completely differently affected during COVID, increased rates of hospitalizations and deaths that you're seeing in many sort of communities of color, particularly those that were part of the multi-generational families who are essential workers in the front line, things that we would have seen coming as potential, vulnerabilities. But it was obvious before that. I think that it was obvious to those of us who are working in emerging infectious diseases when you look at the difference for something like Ebola virus disease, which has forever carried the idea that it has a mortality about 80%. But when you looked at the West African Ebola epidemic, the mortality in returning responders with that disease was less than 20%. It truly tells you how whether you die of a disease completely depends on the healthcare system and the way that healthcare system is built and the access to resources are built on a sense of global injustice, as we move forward to the next phase of this pandemic. The reason I think that this perspective is important is because we threaten to go back to the same nominal scheme where as our communities return to normal, COVID becomes an issue for communities of low resource all over the world. And in this case, it's an issue not just for them, but for us in terms of our return to normalcy. And so next slide. I wanted to start by the punchline first. So if you don't listen to anything else I say, the punchline is truly that and I say that in those who are in pandemic preparedness world, to those who are in outbreak preparedness world, those who are looking at global health security have left the community as a critical component out of the equation. And when we've talked about pandemic preparedness and really community governance, for the reasons that I'll talk about, has to be at the forefront, particularly from the lessons that we're learning from COVID. But then the next thing I want to do is just go through the why it's important, and then end with a couple of comments on the how. So I'm going to show something that when I presented this over the last 6-7 years to my classes, people generally conceived of this as something that happens in resource limited settings, but you'll see how this resonates in all of our communities, particularly when resources are inequitably distributed. Next. So to really detect a new emerging pathogen, right? And you're seeing on the global scene every year and a half, a new human pathogen appear. And that's happening because we're changing the milieu that we're living in. There's almost twice as many people on the face of the earth since I was born, which was about a little bit over 40 something years ago. And the way that we've affected the milieu around us, the balance between our communities and wildlife and domestic animals has changed. And so you're giving opportunities for these new pathogens to spill over into our communities, particularly those who are at the forefront, of trying to make a living, at the barrier between wildlife, between nature and human communities. And so what you're seeing is, there are viruses that are jumping over. And they may even at some point cause symptoms. But for most patients, they would actually recognize, the reason we always fall behind with outbreaks is that we don't recognize the clusters. And this is the reason why we don't. You need to first have people recognize that they have these symptoms and be able to differentiate that. Next. You then need to have people to be able to get to care, even if they were able to get sick, right? So what do most emerging infectious diseases look like? Fever, nausea, vomiting, diarrhea. Do you know what else looks like fever, nausea, vomiting, diarrhea? Everything in my field. And so you have to have communities who are able to get to care. Next slide. You need to then be able to have clinicians who recognize that this is an uncommon disease. And there are studies that show that as of 2014, and this has actually gotten better, 60% of malaria cases worldwide are not diagnosed. They're just empirically treated based on symptoms, which means that people come in, they're given a malaria medication, they go home, they don't get better. And hence they might, if they have something else that's not malaria, that's a chance for that cluster to continue growing as they're able to transmit that to those around them. Next slide. You then need diagnostic capacity to be able to address this. And this will resonate not just for the stories that I've told during the Ebola virus disease epidemic in West Africa, where, by the way, the index case was in December 2013, but it wasn't until March 2014 when the disease had made it into 3 capitals in West Africa that you actually recognized Ebola as the pathogen. And you can say that here in many of our communities, the conversation we had about a year ago about the lack of testing and inability for us to recognize recognize so many of our communities that were, unequally sort of affected because of that inability to get those tests there. Next slide. You then need to have a public health system who's able to report up the threat. Next. And national governments to actually respond with priority and resources, and then an international community that's able to actually respond quickly. So we don't get to, next slide, we don't get to actually pick up most clusters of infectious diseases, because at the terminal end of all infectious diseases surveillances are communities that don't have access to care. And if they don't get care, they are not diagnosed. And if they're not diagnosed, we don't know if there's a new cluster. And I like to propose that we probably live in a world where we miss more outbreaks than we pick up. And there are often potentially cases and clusters that are never diagnosed, and the frequency of those is probably going up. And so that's the existential threat that we're living with, and why health justice and ensuring that access to care and timely access to care is available is important, not just in our communities here in the US, but globally. Next. And then I'm just going to quickly talk about why there's just some unique challenges, right? And why you'll see community involvement is so necessary. Emerging pathogen infectious diseases are particularly challenging to deal with because you're learning about them as you're taking care of them. The first 100 patients teach you about the next one, which means that you are changing the guidance that you're giving to everybody. You are asking them to trust you as you're changing public policy, as the scientific data is changing. And you'll see that distrust that already exists, once you've seen the data evolve around wearing a mask in our communities, or now you've seen the data around potentially airborne transmission versus not. The same exists in every new pathogen's arc as we discovered as it plays out. The other things that make it difficult is that those are usually the pathogens that you don't have facile diagnostics or therapeutics for, so you delay care. And what you're having to do is at all times balance learning about the disease, balancing research, and then response. So you actually need to do investigative work, and hence you need to have some sort of both patient participation and community participation to do that kind of metacognition to learn about the disease. And then there's the ethics of actually conducting that kind of research during an outbreak that can then feed both clinical care and response with public policy. Next slide. And the other part, and I always share this photo, and this is a training that I did with Ebola survivors in 2015, and these were folks who were discharged, and around this time, we first learned that Ebola can cause something called post-Ebola virus disease syndrome. There was a Scottish nurse who had responded and Ebola had returned back, and they discovered that she had an encephalitis type picture, and this was the first time that there was this documentation that Ebola virus disease or Ebola virus could cross the blood-brain barrier. I was in this room when I was reading this story. And I can tell you, many of my West African medical colleagues were like, well, no, actually people are passing away from neurological symptoms here. We just don't have the capacity to diagnose it. In 50% of the people in this room were actually already encountering post-Ebola virus disease syndrome, this entity that, after survival, you still have these ongoing symptoms, cognition symptoms. You might have virus in areas that are immune privileged that may continue for a while. And this is important because the reason we didn't know, when we went back and looked at prior Ebola outbreaks, what we found was that this was happening in most survivors. We just didn't know because we don't tend to stick around. Except for the acute response. And this is not just true of communities abroad, but it's actually true of communities here as well. And how we stick around to get the individual perspective of a patient's arc of disease so we can actually learn about a new disease. And so that sticking around and involvement of the community beyond the acute phase of response becomes important, just so from a scientific perspective, we can learn fully what the disease can do. Next slide. And so here are some things. This is the end, the how, right? I think the reasons, the importance of community-based governance in outbreaks, reason why healthcare institutions, as well as international organizations that are doing this, and there's already a lot of literature here, right, in terms of both community-based development and community-based participatory research. This is nothing new. It just hasn't been applied as much to pandemic response and pandemic preparedness. The reason why it's important is because it helps you identify fault lines. My experience in outbreaks has been that generally societies break along known fracture lines, and getting to know the communities and involving communities in that planning allows you to know those fault lines. It increases accountability because it holds healthcare systems accountable for that investment in preparedness. it builds the trust that's necessary. So when it comes to response, when it comes to actually dealing with a crisis, you already have, members of the community who are aware of the risk, who have already put input into the response strategies. It also allows early detection and reporting of clusters for obvious reasons. And this is a lot more true, I think, in resource limited settings, but it's actually true in many of our communities that may not have access to testing. You can certainly speak about the fact of how immigration status may affect people's ability or willingness to get tested, for example, here in the US as well. And then there could be a participation, of the community in terms of information dissemination, particularly in the setting of a rapidly changing scientific knowledge. You can't really, create that trust in the middle of crisis, whether it's COVID in the US or it is Ebola in Democratic Republic of Congo, where there's a conflict going on. It is always going to be that you have to be there beforehand, to be there present during, and then you have to stay around for the long tail of recovery as well. Next slide. Oh, sorry, just if you could go back one more slide. I just want to point out something. And I'm saying this now today because two things are happening. One is that, IMF has a study that shows, that came out about 6 months ago, that showed that in the aftermath of most epidemics for 5 years onwards, you see income inequality continuing to grow. And it becomes even more important for us to stick around for that long tail of recovery. And not only that, but for many communities, as you can see at the bottom, many countries are not going to see vaccine equity or vaccine access to vaccines until 2013. And then I'll just end very quickly. Next slide. Here are some of the solutions, right? There's direct involvement of schemes such as community health workers and surveillance and response that's already being done. I think the thing that we're spending the least amount of time is greater involvement, representation, and leadership of community-based organization and pandemic preparedness. That's where we fail. We also fail at creation of legislative and community and public health forums that are ongoing, that can function during crisis. And then involvement of communities in research, planning, and execution when it comes to emerging pathogens in particular. And we need to, now that we're looking back at this lens and looking at what lessons to take out of COVID, now is the time to involve our communities to come up with that post hoc analysis. And that doesn't happen enough. It gets closed down into technocratic groups. And this is where I think is another opportunity where you might have community-based governance. Thank you. And I'll pass it on to Alnoor.
Okay, wonderful. Thank you, Drs. Morse and Bhadelia, for those remarkable presentations and the incredible work that you do. I'm going to take a slightly different tack because healthcare is not my specialty. And my specialty is on the challenges facing organizations, all kinds of social change organizations, whether they're nonprofits or business or government, in actually being accountable for their work, assessing their performance as well as their governance. So we can actually take this off of the screen. Yes, the first image you see here on the left is a working paper I wrote about 10 years ago, whose framing Dr. Manchanda has used for these levels of accountability, and that's what I'm going to focus on. And the image on the right is my more recent book, which really looks at strategies for social change. So let's take it off of share screen, and I'll just talk because I won't be using slides. So what I want to do is take those components of accountability that Dr. Manchanda shared earlier and walk through each component. And I'm going to try to pull on Michelle and Nahid's remarks to help kind of populate these different components. I'll try to the best of my ability. Forgive me if I misinterpret. So the components that of accountability that Dr. Manchanda laid out earlier that I articulated in this 2010 paper were transparency, answerability, compliance, and enforcement. And he added this fifth component, which Dr. Bhadelia talked about, which is governance, particularly community-based governance. And you can see as everything being embedded within that. And I think this came across also very strongly in Michelle's work. So let me take each of these components very briefly in turn, just to articulate them in both conceptual but practical terms. So let's start with transparency. It's a term that's thrown around a lot, and we tend to think of transparency as a good regardless. But we need to be careful about it. We know that, HIPAA, for example, there's certain information you can't share because it's private. And we don't want to be transparent about that. But aggregate sort of demographic data actually really matters. So the key to transparency, in my view, is making information available for public scrutiny so that communities and citizens can actually take action on it, right? So they would use this data to hold institutions accountable. And there's multiple components to this. So first of all, the data has to be relevant. We're not facing a shortage of data by and large, we're facing a glut. We're facing a glut of data that is, some of it is unnecessary for decision making. And then we're facing a shortage of stuff that we actually really need to gather data on. So we need relevant data. Dr. Morse sort of talked about, she was able to document in her work unfair access to resources by race, right? That's data that we really need, and we need to make it transparent in all sorts of healthcare settings. She found that white patients advocated to be admitted to cardiology and that this influenced physician decisions. Really important data point, right? Who's going to advocate for non-white patients? Or can we have a system where actually advocacy is not so essential? So having transparency, having relevant data. Second is having timely data. So it's made available in a period of time where people can actually act on it. Civic groups and so on. So not after key decisions have been made, but before key decisions have been made. And making it accessible to people who need to make those decisions so that they can get that data easily and affordably. My own work came at this issue from, I had done some work on the World Bank's information disclosure policy, and gave a congressional testimony on this about a decade ago. And had been looking at the bank's work in poverty alleviation, particularly in large infrastructure projects. So imagine that they're working with a major government to build large dam projects, hydropower projects. These tend to displace tens, if not hundreds of thousands of people, mostly rural people without much of a voice. So the decision-making around that, what's the project gonna look like? When's it gonna be implemented? Where is it gonna be implemented? You need transparency of information so that people can actually act on it and begin to change the parameters of that. It needs to be relevant, timely, and accessible. So in healthcare equity, right, data that's collected and disaggregated by race, ethnicity, gender, also language. You know, that recent article by the folks at Families USA that Dr. Manchanda had on one of the opening slides in Health Affairs, talks about language actually being an important sort of part of the data collection. Data on what types of services are available, who has access to them, and in fact, sort of all of the work on upstream, so much of it is about trying to understand who has access to what, and maybe reaching out to communities who are not actually having access, and as a result, we don't have any data on them because they're not part of the system. So we need to find ways of reaching those folks. So that's the transparency piece. The answerability piece is really about asking the question to any organization or institution, on what basis, on what rationale do you provide certain services to certain groups and not to others? Both in terms of the services as well as to whom those are provided. We know that you can't serve all types of services to everybody, and you have to prioritize your resources. And so in some places, you'll prioritize primary preventive healthcare. In other places, it'll be tertiary, really highly specialized. You can't do it all. And so, but you need, as an organization, to be very clear about what you're doing and why. That's the answerability piece. You're providing a rationale, a justification. In the language of management, it's what's your strategy, right? Can you lay that out explicitly so that it can be reasonably questioned, challenged, and improved upon?
Professor Ebrahim, I'm going to share a screen because I think what you're mapping along right now, there's some graphics that go really nicely with this. I'm just going to keep going. But
right, so the implication for equity in healthcare is, you know, what we've learned from the social determinants of health work, and you know, Dr. Bhadelia's comments about responding to global health pandemics, is that healthcare requires a strategy that's at an ecosystem level. Right? No single entity or organization can address our major healthcare problems. And so we need an ecosystem level strategy in addition to an organization level one. So you can imagine clinics, hospitals having particular strategies, but then there would need to be some way of framing that as a collective. And the collective must be answerable. So as a question I pose to this community, because you'll know it better than I, are coordinated care organizations or accountable care organizations here in the US, are they a particular model for a collective, an ecosystem level strategy? Are they explicit about their strategies in terms of who they're serving and for what and what they want to be accountable for? And if not, can they make it explicit so that that can be challenged and improved upon? That's answerability. The third piece is compliance. Now, I've changed my own thinking about the word compliance because at one side, it's a harsh word. It suggests clear standards and an ability to monitor if those standards are or are not being met. Whereas for much of the work that's on the front lines today, we don't have clear, unambiguous standards. We're trying to develop them as we build. And so, you know, if you've got an ambulance service in India, I've worked with one, it's called Zikitsa Healthcare Limited. They have rigorous standards for the quality of ambulances and training of staff. But if you're actually trying to get entire organizations and networks of organizations to actually learn together, to build new models of collaboration together, then perhaps compliance is not the right way of thinking about it. Perhaps collective improvement is the way of thinking about it. But it's this connection between having some set of objectives that we can monitor our progress on, and then partnering that with a conversation around how could you improve this? And I think this requires a monitoring of both processes and outcomes. And so, you know, Dr. Morse talked about, you know, really monitoring health outcomes and looking for opportunities for redress. Dr. Bhadelia laid out sort of this incredible logic about a patient seeking help, having the ability to get care, a clinician recognizing an uncommon disease, lab tests, you know, confirming that, the public health system reporting it up, and then some sort of a response, and then monitoring that over the long term. She's laid out a process, and you can imagine monitoring, setting in place monitoring procedures at every level of that to see what kind of response we're getting and what could be improved along the way. In the end, you're also tracking outcomes, but you're tracking the process as well. So combining some view of what the process looks like with what kinds of outcomes that would lead to turns out to be really key in the compliance and improvement bucket of this. And then finally, there's the enforcement and sanctions piece of this. And so here, we do want to have some kinds of consequences, right? So, you know, in one way you might think about, well, does the public sharing of information about outcomes lead to public shaming of institutions that are performing poorly? There wouldn't necessarily be direct sanctions, but the embarrassment of being shamed could actually lead to better performance. And we've seen this with labor standards, for example, in different parts of the world. But you could also have sort of harder consequences, which would be federal monies, for instance, right? Withholding pay for performance type stuff, withholding funding unless there's actual a show and improvement. My caveat there is that tough enforcement also has a dark side, because we want to be careful about punishing poor performers, because perhaps poor performers actually need support to perform better and might actually need deeper investment. We know this about health systems. We know this about education systems. One of the big pushbacks in the education field against the No Child Left Behind legislation during the George Bush years was that you could end up punishing the school districts that actually were performing poorly because they actually needed more support. And so we need to be careful about the sanctioning mechanisms, but being able to both enforce and support at the same side. All four of these components, transparency, answerability, compliance, and enforcement, require community-centered governance. And so we need to think about the role of community in the data gathering, in the monitoring, in the enforcement as well. So let me stop my remarks there and hand it back over to you, Dr. Manchanda.
Professor Ebrahim, thank you so much. And some of what you beautifully kind of just remarked on and then tied back to comments from Dr. Morse and Dr. Bhadelia is our attempt, I think, to start to create a framework, identify the concrete mechanisms and questions to do a deeper dive on this question of accountability. And Michelle, in particular, as Nahid, as you guys are both presenting, part of what I took from your comments was reflected over here in terms of some of the elements, the mechanisms that need to be in place for community-centered governance. And I also, to your point, Michelle, with the recent article and the work with ARC that you've been doing, put in this notion of reparations. And I think, as you can see my framing of the question over here, I just wanted to elevate this point because it's getting some good response on our chat, but I know there's been a lot of discourse that you've been involved with regarding this question as well, as many have. But I do think it's a powerful statement to say, well, if structural racism, colonization, economic exploitation are by definition about extraction, and if healthcare institutions have, wittingly or unwittingly, benefited from or even been complicit in that history, then there must be some sort of reparations for that extraction, right? For that extractive practice for many years. What kind of reparation is each institution planning to provide to further its work, its anti-racist decolonization, economic justice work? You can see some of the other elements there in terms of participatory governance, centering in margins, but each of these components, as Professor Ebrahim just walked through, are relevant both for the field more broadly in terms of nonprofit accountability, social change, but especially I think relevant as we found it in the context of health equity and racial justice work. We've had a lot of conversation here and an attempt to try to provide a list of the mechanisms that could be helpful to bolster institutional accountability. Let's launch this on a third poll as we come into the home stretch here. And hopefully you guys have all found this as fascinating as I have. But let's ask about what this means for you as you're thinking about these concepts. Which of these mechanisms of accountability for health equity and racial justice are you interested in learning more about or even strengthening as part of your work? And there should be a choice that says all the above. So perhaps you can set out the poll if you want to answer all the above and just answer that in the chat later. Is it building community-centered governance, including questions of reparations? Is it building transparency around how health equity-related data is captured and communicated, made available to public scrutiny? Is there answerability, where the rationale for decisions made or not made, actions taken or not taken, are also made available for public scrutiny? Is it compliance? The idea of actually putting in place monitoring and evaluation processes to make sure that the work of health equity continues effectively and equitably, or is it enforcement or sanctions or consequences? Go ahead and end the poll now. 2/3 of you responded. Thank you for that. Large number are looking at community-centered governance aspects, and then I think an interesting split across the other ones as well. So really helpful just to hear your take on where you want to learn more in this way. Really helpful baseline for us. And as we kind of open this up in terms of the conversation, I'm going to stop screen sharing here and just say, Michelle, first, you went early on and you've been hanging through this conversation. I'll go to Nahid next. When it comes to the conversation so far today, the dialogue, what's the first thought that comes to mind for you right now as you reflect on your work and then the rich dialogue we've heard already? What's coming to mind for you?
Yeah, just that we have so much work to do. I think ultimately the conversation is so enriching, and it's always helpful to have framework. So I appreciate the chance, of course, to talk about Healing ARC, but really also appreciate what Alnoor presented in terms of how to organize our thinking on this, and loved Nahid's thoughts about community-led accountability. I think that's huge. And the last thing I'll say is just that I think, using the term reparations is a term that we have to use with caution, because I think there have been generations of movements for reparations, particularly for Black American descendants of slaves in the US. And I think that the term is a term that is considered really, precious and important. And it's not to say that, we can't use it. It is to say that we have to use it with a lot of intentionality. And I think that's part of the reason we also see redress and restitution and other terms being used, but it's often kind of reserved for specifically kind of that federal reparations program. And I would also say at the same time, I think that a big part of what we're hoping to do with Healing Arc in this next phase of implementation is actually really hearing from patients with heart failure in the communities we serve to understand, you know, what it would look like for them, like at what point would they see restitution and closure as, you know, accomplished. And so those are the kinds of questions I think we're pushing ourselves to try to explore more and answer, and recognize again that, you know, again, the community priorities have to be first and foremost for this work.
Thank you. Thank you. Exactly. So, and Naheed, what's
I think I was struck by, you know, the knowledge that exists in all these different disciplines and how much we can gain by exactly as Alnoor presented the you know, and Michelle, the stuff that you're talking about, the work. I mean, if we could borrow all of these frames of reference and apply it to these, you know, problems that are not new, but certainly these kind of questions are not asked enough, right? And particularly in my field, or enough as much as they should be, and as central as they should be. But the other thing I wanted to reflect on, Alnoor, you talked about the idea of organizations existing in an ecosystem, right? And so when you present that metric, I was sort of trying to think about our ecosystem in response in global health security, particularly about pandemics. And the referent object is the state. Is it the state? Is it the community? Is it the healthcare system? Is it the, you know, and it's important because then it kind of goes down to what you were talking about, particularly around sanctions. Certainly you're like, who's holding people responsible? Who is, you know, and the referent object is kind of important in this discussion, because certainly in the international level, when we talk about like building that capacity, equity is like, we haven't even reached equity because we have not even started at getting just enough of a distribution to sort of get capacity worldwide, right? The International Health Organization, the way the countries relate to each other, said that you need to build capacity to do, you know, surveil, detect, and respond to these pathogens. Less than 20% of the world's countries actually have that capacity as of the last, you know, the evaluation that we did. And this trouble of like, if you punish the very people who don't have that capacity, you may actually, you know, hurt them. And so what's the way to do that carrot and stick to have countries invest more in this type of stuff? So I'll just stop reflecting there, but that's what I was thinking.
Yeah, I'll learn it too.
Sure. Yeah, I do think one of the things that I've been thinking about lately is, you know, what are the different models for kind of central ecosystem players, right? What I call ecosystem orchestrators, because they're really trying to deal with a whole bunch of different actors. You know, it's partly what HealthBegins does, right? Where you're really trying to pull together the different key players within an ecosystem that have some role in addressing some particular social or health problem. And those are necessarily going to look different in different political contexts. So I've done work on this in the context of urban homelessness, chronic homelessness, where we're beginning to make progress around permanent supportive housing or housing first models. And there you sort of put the most vulnerable clients in housing, and then you wrap around all of these services, you know, around health and substance abuse and job training and so on around them. But who plays that orchestrator role in terms of galvanizing all of that work? In some cases, it's been city government, but in pretty limited numbers of cases, just in the US, where we've got a reasonably similar political system across the country. In many cases, it's been nonprofits, you know, that have sort of taken on that role, or collectives of nonprofits. And in other cases, we're beginning to see business take kind of a leading role. So who are those orchestrators? What do they look like? And can we find ways of building their capacities so that they adapt to their local political and social context for doing that? And so government may not be the answer in all instances, though probably at a national level, it has to be a key part of the answer.
Right. We are about a minute away from wrapping, and clearly this is, as I talked about at the top, the tip of the iceberg in terms of this conversation. I think that questions have come in that I know we don't have time to address right now, but questions speaking of capacity of, you know, what's the capacity of grassroots constituencies, right, to be able to hold healthcare institutions accountable? What related levers or mechanisms concretely can communities use to be able to hold, especially in the context specifically of health equity and racial justice? hold healthcare institutions accountable? How can internal leaders, right, work as allies to be able to help model this internally, and then also broker relationships with external stakeholders to in a constructive way, hold themselves accountable? And lastly, just a comment, as Michelle, you rightly pointed out, and as Alnoor, you mentioned, clearly, as we're taking some of these frameworks and then applying it, the praxis of this requires us to adapt. And so we, not reparation, but redress or restitution, not compliance, but collective improvement, not enforcement or sanctions, perhaps even, as some have already commented, but consequences. And regardless of, in addition to the appropriate intentionality around terms, there's also intentionality around what it means in practice. This conversation was meant to just start this dialogue, to address a gap that exists in the country right now, at least in the US, when it comes to how we move forward in health equity and racial justice, and no better group of experts in the nation to help start this conversation than Dr. Michelle Morse, Dr. Bhadelia, and Professor Alnoor Ebrahim. I can't tell you how grateful we are. We are going to continue this conversation, looking forward to working with each of you in every capacity that you're available to continue being part of that conversation. And with many of you online as well, as we move this forward, because we know that accountability needs to be built as we're looking at driving equity. Thank you so much to each of you guys. Looking forward to our one-on-ones and conversations in general. And thanks to each of you for joining today. You're gonna get a follow-up survey. You're encouraged to stay engaged with us through a lot of conversations on social media, and also just take action in the ways that you can to be able to bolster accountability. With that, I'll let you guys all go. We will be in touch. Michelle, thank you. Nahid, thank you. Alnoor, thank you so much.